Diabetes mellitus affects over 30 million people in the US, with 1.5 million new cases developing each year. And as obesity rates soar, these numbers will only grow more rapidly. Diabetes is characterized by impaired glucose metabolism due to defective insulin secretion, increased insulin resistance, or both. And when insulin isn't doing its thing, that means hyperglycemia. Chronic insulin resistance and hyperglycemia affects virtually every organ system and can lead to serious complications, including blindness, renal failure, limb amputations, stroke, and heart attack. But hey, they wouldn't call this the fastest, deadliest, most revered racing series in all of Candy Valley if there weren't some danger involved. Welcome to the annual Candy 200. Brace yourselves, friends. Peanuts will be cracked, caramel will be spilled. But in the end, there will only be one victor. The prize? A lifetime of prestige and chronically elevated blood sugar. Sounds pretty sweet, huh? Type 1 diabetes will be represented by race car number 1, which seems to have been hastily constructed using only a gum wrapper, an ice cream sandwich, Neapolitan no less. And what are those? Werther's Originals? Pretty good wheel choice for this course, actually. Type 1 diabetes is much less common than type 2, accounting for only about 10% of all diabetes cases overall. It typically presents in childhood or adolescence, though about 1/4 of patients will present in adulthood. See those jelly beans working the pit stop? Carting away those used wheels? Well, those aren't butterscotch candies. They're beta scotch. And the beta is there to remind you of the insulin-producing beta cells in the pancreatic islets of Langerhans. Notice, too, that antibody wrench still attached, evoking an image of the underlying pathogenesis of type 1 diabetes. What we're dealing with here is autoimmune destruction of pancreatic beta cells, which creates a state of absolute insulin deficiency. At Sketchy, our recurring symbol for insulin is a welcome inside mat, like this one, highlighting the hormone's job of bringing glucose inside the cells. Insulin is your classic anabolic hormone, and we'll be bringing this symbol back over and over again throughout this chapter. In this scene, that rolled up welcome mat represents decreased insulin levels in the setting of type 1 diabetes. Destruction of beta islet cells in type 1 diabetes starts with T cells losing their self-tolerance. For some reason, they start going crazy for your own beta cell antigens. This results in a CD8 killer T cell mediated attack of the beta cells. At Sketchy, killer T cells are symbolized by Crusader Knights. So why not enjoy a smooth, chewy Three Crusaders bar while watching the race unfold? Just kidding. Only nougat. No, thank you. Anyways, it's not just the killer T cells who are involved. Pathogenic CD4 helper T cells recognize a few self-antigens of their own. Not only do they accentuate the killer T cell response, they also activate B cells, which start to produce autoantibodies. B cells are, as always, symbolized by antibody archers. The autoantibodies they're secreting latch onto all kinds of antigens found right inside your body's own pancreatic beta cells. You're just shooting yourself in the foot. Or pancreas, as it were. The brand name glutamate should remind you of anti-glutamic acid decarboxylase antibodies, while the word inside highlights the presence of anti-insulin antibodies. Both of these immunoglobulin varieties are commonly detected in patients presenting with type 1 diabetes, in addition to many other beta cell-specific autoantibodies. Now, let's back up a bit. What caused the CD4 and CD8 T cells to go crazy in the first place? Well, it's a combination of genetic susceptibility and environment. The good old nature versus nurture scenario. Let's start with genetics. There's a strong association between type 1 diabetes and major histocompatibility complex polymorphisms, especially the haplotypes HLA-DR3 and DR4. And what do these genes encode? MHC class II molecules, of course, which are responsible for antigen presentation. So, in essence, antigen presentation is screwed up. Helper T cells are presented self-antigens, get activated anyways, and start organizing the immune system against your pancreas. This whole genetics business is summed up by the lights on the side of the track. 1, 2, 3, 4. That's diabetes type 1, with a weird-acting MHC class II, associated with haplotypes HLA-DR3 and DR4. So that's the nature side. Now a brief word about the nurture. It's not really well understood, but molecular mimicry may play a role here. Let's say there's a virus that makes a protein very similar to insulin. The T cell recognizes that protein as non-self, and B cells are stimulated to make antibodies against it. But since you have a similar antigen in your beta cells, your pancreas also gets attacked in the process. This is a classic case of type 2 hypersensitivity, the immune system's version of friendly fire. Besides viruses, there are a number of other environmental factors that might contribute to the development of type 1 diabetes. But again, the pathogenesis is not too clear. Well, as you can tell, patients with type 1 diabetes harbor an immune system that's just ready to attack. It's probably not hard to imagine, then, that these patients are at an increased risk of developing other autoimmune diseases, such as Graves' disease, Hashimoto's thyroiditis, and celiac disease. Okay, next, let's look at histology. First of all, recall that the pancreas is mostly comprised of exocrine acinar cells, and only a small percentage is made up of endocrine cells, which live inside those fancy islets of Langerhans. The islets are typically more pale staining compared to the acinar cells, and they contain the insulin-producing beta cells. This is recreated on the other side of the candy box there, with those pale islands highlighted. In the setting of type 1 diabetes, the pancreatic tissue will show a lymphocytic infiltrate composed primarily of those T cells we were talking about earlier. All those little blue candies are meant to evoke an image of an infiltrate of inflammatory cells. All those little blue nuclei. And we're attacking islet cells, remember. So expect to see a reduction in the number and size of islets, as illustrated by the squashed islet candy. Turns out you need to destroy a pretty significant percentage of functional beta cells to finally see some clinical symptoms. In some individuals, progression is so slow that autoimmune destruction occurs for many years before symptomatic hyperglycemia develops. Remember that what we're dealing with here is an absolute deficiency in insulin, as symbolized by that rolled-up welcome mat. Insulin is an anabolic hormone, normally responsible for bringing glucose into muscle and fat cells. A cell's gotta eat, you know? Once the glucose is inside, insulin stimulates the synthesis of protein and fat. Furthermore, insulin usually blocks liver gluconeogenesis and inhibits breakdown of glycogen, or glycogenolysis. So, in the setting of type 1 diabetes, when there's no insulin around, expect the opposite to occur. First of all, see how those glucose candies are bouncing off the cell? Without insulin, the body has a hard time moving glucose into peripheral cells. So blood glucose will be elevated right off the bat. On top of that, the body shifts from an anabolic state to a catabolic state. Instead of building up energy stores, you're breaking them down. This means increased muscle and liver glycogen breakdown, as well as increased liver gluconeogenesis, which sends blood glucose levels even higher. Hyperglycemia is embodied by the spectator back there, raising that candy jar in the air, letting that sweet glucose course through his veins. When the filtered glucose is high enough to exceed the kidney's capability to reabsorb it, glucose also starts to spill into the urine, also called glycosuria. Glucose is an osmotically active solute, which means that when it's eliminated, it drags water along with it. This leads to an abnormally large volume of urine, polyuria in other words. All this renal water loss, in addition to the extra glucose sitting in the blood, leads to an increase in plasma osmolality, as highlighted by the conned osmiment stand in the back. Hyperosmolality triggers osmoreceptors in the hypothalamus, leading to a feeling of intense thirst, also called polydipsia. Also called disgusting. Remember, because there isn't much insulin, the liver is going gluconeogenesis crazy. To provide extra substrates to the liver, muscle cells are broken down into amino acids, which are then sent over to the liver to make new glucose. Insulin deficiency also leads to increased hormone-sensitive lipase activity, resulting in adipose tissue hydrolysis. At Sketchy, fat breakdown is symbolized by fatty donuts getting munched. All in all, fat and muscle breakdown leads to weight loss. These patients are not utilizing the body's sugar effectively, though. So, despite all the weight loss, keep in mind that they'll still have an increased appetite. Think of it this way. Even though you have all that sugar floating around, it's effectively locked out of your body's cells. They're hungry. Oh, God, that's good. I'll finish these later. Increased lipolysis also leads to ketone production by the liver. So let's sketch in some more fatty donut breakdown, along with our recurring symbol for ketones, the candy key. Ketones are used by the body cells when glucose isn't available. This might be helpful if it weren't for the fact that, at high levels, They can cause a severe anion gap metabolic acidosis. Stack on a severe volume depletion and a couple of electrolyte disturbances, and you've got a seriously dangerous and life-threatening hyperglycemic crisis, also known as diabetic ketoacidosis, or DKA for short. More on that bombshell a couple sketches from now. So how do you treat type 1 diabetes? Well, as Mary Poppins says, a needle full of insulin helps the sugar go down. Because you're losing your insulin-producing beta cells. Medications for type 2 diabetes that stimulate insulin secretion usually do not work here. For type 1 diabetics, you gotta replace that missing insulin. For more on the ins and outs of insulin therapy, check out the Insulin Sketchy Farm sketch. It's a spooky good time. Ooh, I've got a fun math question for you. Ricky has 46 candy bars, and she eats 39. What does she have now? Type 2 diabetes and wide open Saturday nights. Over next to car number 2, we're going to illustrate everything you need to know about the most common form of diabetes, type 2, which accounts for over 90% of all cases. While type 1 diabetes is caused by an absolute deficiency of insulin from autoimmune destruction of beta cells, type 2 diabetes mellitus is caused by a relative insulin deficiency from a combination of insulin resistance and beta cell dysfunction. For insulin resistance, think of this jelly bean pit stop crew guy above the welcome inside mat. Notice that he's trying to pull her out of that donut car, but is getting some resistance. And to remind you of beta cell dysfunction, we've made one of the beta scotch wheels malfunctioning. I mean, come on. Everyone knows you don't use a butterscotch wheel set up on a chocolate bar. And what is that? Custard filled? Please. As my pappy used to say, "Give me an old-fashioned donut and I'll show you how to win a race." I'm just kidding. My dad doesn't sound like that. Speaking of dads, there's also a much stronger genetic component to type 2 DM. Almost 40% of patients with type 2 DM have a parent with the disease. Additionally, there's an 80 to 90% concordance rate in monozygotic twins versus only 50% concordance in type 1 diabetes. That said, the pathogenesis of type 2 DM is definitely multifactorial and involves a few important environmental factors, such as a sedentary lifestyle and poor diet. One of the most important environmental factors that contributes to insulin resistance is obesity. Excess fat, especially around the abdomen, may alter insulin signaling through several different mechanisms. For example, adipocytes are capable of producing all kinds of wacky cytokines, also called adipokines, such as leptin, adiponectin, TNF-alpha, and resistin. An imbalance of these factors can lead to insulin resistance. Probably too many cytokines and not enough adiponectin. The barricade of fatty donut jars is meant to evoke an image of adipocytes, with that spectator holding out the bag of cytocoins, depicting the various adipokines released into the circulation. Car 2 broke down a little too easily, and now money is exchanging hands. Granted, it's chocolate coins. Still looks a little suspicious. It's also been shown that intracellular triglycerides and free fatty acids are potent inhibitors of key insulin signaling molecules within the cell. This is illustrated on the side of the track, where one of those jelly bean dudes is trying to signal the rest of the racers that a crash has occurred. Unfortunately, his signal is broken. Also, notice that the fence holding him back is made of fatty acid chains. And thirdly, it's been shown that free fatty acids within macrophages and even right inside the beta islet cells can activate the cytoplasmic inflammasome. Sounds ominous, right? In turn, these cells secrete several inflammatory mediators, including interleukins, which promote insulin resistance at peripheral tissues. What? More cytocoins are being exchanged? No, I don't mean to be racist or ethnocentric or ornithischian or whatever. But never trust a peppermint. Spearmint? We're good. Wintergreen? All right, so that was insulin resistance. When insulin can't do its job out in the periphery. We had adipocytes releasing hormones and cytokines, fatty acids accumulating in cells and interrupting insulin signaling, and fatty acids accumulating in macrophages and beta cells activating the release of more cytokines, altogether inhibiting insulin's ability to work in the periphery. How about dysfunction of the pancreatic beta cells themselves? We've covered insulin resistance, and now it's time to look at the other side of the equation, problems with insulin production. At first, when your body starts becoming resistant to normal amounts of insulin, the pancreatic beta cells respond by increasing insulin production. Hence the excessively tall stack of insulin mats placed next to the car so that Tutti Frutti up there can reach the driver's side door. Over time, however, the beta cells can no longer keep up, and there's a relative deficiency of insulin. This is a process known as beta cell burnout. So what's up? Why did the beta cells start lagging behind? Well, remember that genetics probably plays a big role. Maybe your mom gave you bad beta cells, you know? Thanks, Mom. Thanks a lot. What else? Let's see here. Oh, I know. How about excess glucose and free fatty acids building up inside the beta cells? This activates local cytokine release and disrupts beta cell function. An important signal for beta cell insulin release comes from the intestines, actually, in the form of incretins, such as GLP. Maybe incretin communication between the GI tract and the pancreas is interrupted for some reason, leading to inadequate GLP stimulation of the pancreas. Gulp. It's not really clear, so, just throwing that one out there. Check out the driver's name, Amy Lynn. It's meant to remind you of amylin, a polypeptide that's normally co-secreted with insulin from beta cells. It helps out with glycemic control by regulating things like gastric emptying and satiety. Now, in patients with chronic type 2 diabetes, amylin is not processed properly and gets stuck inside beta cell secretory granules, where they form amyloid aggregates. This is depicted by the pink amyloid gunk that's mucking up the wheel. Under the microscope, the amyloid starts to deposit around capillaries and between cells and, over time, can take over most of the islets, which may also show fibrosis. There's also some evidence to suggest that amyloid is toxic to beta cells. But, again, it's not really clear whether amyloid is causing the beta cells to burn out, or conversely, beta cells are already burned out and just start collecting amyloid. Like, as a fun hobby. 'Cause, they're retired and all. I kind of feel like I'm digressing. All right, so now we have a few factors possibly contributing to beta cell dysfunction. Crappy genes, glucose and lipids inside the beta cell just being annoying, ineffective GLP signaling from the GI tract, and amyloid accumulation, which may be just an effect of beta cell burnout and not a cause. It is just not her day. All right, one last point to make about pancreatic beta cells in type 2 diabetes. Turns out that you don't just have malfunctioning beta cells, but you also start losing beta cells, represented by this last beta wheel here, rolling out of the scene. Amyloid accumulation is also known to be a mediator of cell apoptosis. But on top of that, other factors, such as intracellular glucose and fatty acid toxicity, can cause oxidative and organelle damage and send even more beta cells into programmed cell death mode. Keep in mind, however, that even though type 2 diabetes is associated with a decrease in beta cell numbers, this is not the main driver of insulin deficiency in these patients. Don't forget about beta cell dysfunction. All right, let's get clinical. Typically, type 2 diabetes usually presents in older, obese patients. Compare this with your typical young, thin type 1 patient. Don't get too stuck on the age difference, however. With the increase in childhood obesity, type 2 diabetes is popping up in children more often than in the past. Patients with type 2 diabetes can present with polydipsia, polyuria, and polyphagia, just like in type 1 diabetes. However, type 2 diabetes is more likely to be diagnosed in asymptomatic patients. They're in your office for some routine blood work and, you notice their blood glucose is a little high. People with long-standing type 2 diabetes who have not received regular medical care may also have some systemic signs and symptoms of long-standing hyperglycemia, including blurry vision, paresthesias caused by peripheral neuropathy, and recurrent infections. A grandfather clock, like that big gingerbread clock in the stands, is our recurring symbol for chronic disease. And it's here to remind you of the many complications of chronic uncontrolled diabetes. These will all be covered in their very own sketch at the end of the chapter. So stay tuned. An acute, life-threatening complication of type 2 diabetes is hyperosmolar hyperglycemic state, or HHS for short. HHS is characterized by severe dehydration due to the ongoing osmotic diuresis driven by hyperglycemia, kind of like what we see in DKA. In contrast to DKA, however, patients with HHS do not have ketoacidosis. Because this condition is also called hyperosmotic hyperglycemic non-ketotic state, or HONK, we've added a car honking as it approaches the pit stop. We'll talk about HHS and DKA in much more detail in our next sketch at the finish line. All right, how about treatment? In type 2 diabetes, it's super important to encourage lifestyle modifications, including weight loss, physical activity, and dietary changes. Medications are often a part of therapy as well, but unlike type 1 diabetes, insulin is usually not the first-line treatment unless the type 2 diabetes is poorly controlled. Most patients with type 2 diabetes have endogenous insulin. It's just that their cells aren't using it correctly. So you can use special anti-diabetic medications that both decrease blood glucose levels, as well as increase the effectiveness of the body's own insulin. You can learn all about these medications in our Sketchy Farm course. Okay, time to look at labs. To diagnose diabetes mellitus, we need to look at blood glucose levels. And there are a couple of different ways we can do this. First, we can take a random blood glucose measurement, hence the random array of colors displayed on the flags. If a random glucose comes back greater than or equal to 200 milligrams per deciliter, along with clinical symptoms such as polyuria, polydipsia, and polyphagia, you can make the diagnosis of diabetes without having to repeat any testing. If the patient is asymptomatic, you'll need to repeat the test on a different date to confirm. Regardless, the big number to remember here is 200. Instead of a random measurement, how about we plan ahead a little? To obtain a fasting blood glucose, your patient must refrain from caloric intake for at least 8 hours. A fasting serum glucose greater than 126 milligrams per deciliter on 2 separate occasions is also diagnostic of diabetes. While it's typically used more frequently in the obstetric realm, an oral glucose tolerance test can also be used to diagnose diabetes. In an oral glucose tolerance test, 75 grams of glucose is administered orally and serum glucose is checked 2 hours later. If the level is greater than or equal to 200 milligrams per deciliter, the patient officially meets the criteria for diabetes. Now, in addition to just straight up measuring the glucose molecules floating around in the blood, we can also look at how much is glommed onto hemoglobin. You see, red blood cells are freely permeable to glucose, and when glucose sneaks inside, it likes to bind onto hemoglobin through a process called non-enzymatic glycation. Glycated hemoglobin, also called hemoglobin A1C, is represented by the glycating streamers hanging off that Formula One car with the hemoglobin wheels. Formula A1, that is. The level of hemoglobin A1C actually gives us a better picture of longer-term glucose control, because the hemoglobin stays glycated over the lifetime of a red blood cell, about 3 months. Think of hemoglobin A1C as an indicator of your patient's average glucose levels over the last 3 months or so. See the 6 and 5 incorporated into the design of the A1 car? A hemoglobin A1C concentration greater than or equal to 6.5% meets criteria for diabetes, though technically, the test needs to be repeated to confirm the diagnosis. Although type 1 and 2 diabetes mellitus are commonly tested, don't forget about the other diseases that can lead to the same clinical signs and symptoms of hyperglycemia, such as Cushing syndrome, hemochromatosis, PCOS, and glucagonoma. Check out the respective Sketchy Path sketches for all the sacchariferous details. All right, time to wrap this thing up with 2 additional diseases of insulin resistance: metabolic syndrome and maturity onset diabetes of youth, or MODY for short. At Sketchy, we represent metabolic syndrome with a calorie-laden serving of metabolic brownies. They're being served to the king of Candy Valley himself as he watches the race below. Metabolic syndrome affects close to 25% of Americans. And as obesity rates continue to increase, that statistic isn't going down anytime soon. There are actually a couple of different definitions for metabolic syndrome, but essentially it involves a constellation of signs and symptoms including abdominal obesity, hyperglycemia, hypertension, and dyslipidemia. As in the case with type 2 diabetes, there can be a familial predisposition to developing metabolic syndrome. Thanks again, Mom.
You're welcome, Ricky. Oh, I left the casserole in the fridge for you.
Oh, sweet. As we discussed with type 2 diabetes, excess adipose tissue can cause direct inhibition of insulin signaling, as well as inflammation that can worsen insulin resistance. And remember, it's the central stuff that's the worst. You know, the visceral and abdominal adipose tissue. This is highlighted by the King's tailor, trying to get his tape measure around all that abdominal girth. That brings us to diagnosis. It really depends on which guidelines you're using. But if we go with the most commonly used criteria, it requires the presence of 3 of 5 characteristic findings. Hence the 3 prongs on the fork he's wildly brandishing. What you're looking for is a fasting glucose greater than or equal to 100, blood pressure greater than or equal to 130/85, triglycerides greater than or equal to 150, HDL less than 40 in men or less than 50 in women, or a waist circumference greater than or equal to 40 inches in men and greater than or equal to 35 inches in women. So why is metabolic syndrome important? Couldn't a hypertensive patient just have low HDL and be a little on the chubby side? Well, sure. But metabolic syndrome increases your risk of developing other diseases. I'm not going to sugarcoat it. Patients with metabolic syndrome are about 2 times more likely to develop cardiovascular disease. Wow. Sorry there, buddy. Actually, you know what? Never really liked those candies anyway. Too chalky, you know? And they always say weird stuff like, say yes and crazy for you, or like, stalk me if you have time. Not into them. Also, we've made the Candy King pointing ominously at racer number 2 to emphasize that patients with metabolic syndrome are 3 to 5 times more likely to develop type 2 diabetes. Not surprisingly, management of metabolic syndrome involves lifestyle changes including diet, exercise, and weight loss. Pharmacotherapy may be needed to manage hyperlipidemia or hypertension, for example. And finally, mature onset diabetes of youth, or MODY, characterized by the development of non-insulin dependent diabetes at a young age, usually before the age of 25. Non-insulin dependent means we're dealing mostly with insulin resistance rather than an absolute deficiency, kind of like type 2 diabetes. So we have our young moody prince here, pointing down towards that type 2 diabetic racer. MODY is transmitted in an autosomal dominant fashion, hence the dominant domino symbols incorporated into the shutters. And in contrast to type 1 diabetes, patients lack autoantibodies. The autosomal dominant genetic mutations associated with MODY affect everything from beta cell development to glucose sensing to insulin secretion. Definitive diagnosis can be made by testing for these genetic mutations. And that's it. We've unwrapped everything you need to know about the pathogenesis of diabetes. Recall that type 1 is an autoimmune-mediated disorder characterized by beta cell destruction and an absolute deficiency in insulin. Expect an inflammatory infiltrate on histology, mostly T cell, by the way, as well as a decreased number of beta cells and islets of Langerhans. Genetics-wise, just remember 1, 2, 3, 4. Type 1 diabetes, a messed up HLA-2 gene, specifically the HLA-DR3 and DR4 haplotypes. Classically, patients with type 1 diabetes are thin. Think of it this way. Without insulin, you can't move glucose into cells to store as fat. Not only that, but you've got rampant gluconeogenesis that's stealing amino acids from muscle, as well as overactive hormone-sensitive lipase breaking down your fat stores. All that catabolism makes them hungry. Meanwhile, type 2 diabetes is characterized by insulin resistance. At first, insulin secretion increases to compensate, but in later stages, the beta cells get burned out, resulting in a relative insulin deficiency. By relative, I mean that there's usually some insulin left, just not enough for the body's demands. Family history plays a big role here.
You're welcome, Ricky.
And the biggest modifiable factor is obesity, especially that abdominal kind, messing with that insulin signaling. And finally, we reviewed the metabolic syndrome, which is associated with an increased risk for developing cardiovascular disease and type 2 diabetes. Then there's maturity onset diabetes of the young, a type of moody, non-insulin dependent diabetes that's inherited in an autosomal dominant fashion and usually occurs before the age of 25. All right, to sweeten the pot, we have a second video that goes into detail about the complications of type 1 and type 2 diabetes, focusing on DKA and HHS. So I'll see you at the finish line.